So just till I think everyone joins in about 5 minutes, I'll give a brief context of why we're doing all of this.
Yeah,
So
sounds good.
this is so the Rheumatology Association of Gujarat does an yearly conference. This is called as RACCon, and this year we are doing it as a immunoallergy conclave. So in India, the degree is called as Clinical Immunology and Rheumatology, and uh, somehow in the middle of all of this, allergy didn't get the degree of importance it probably wanted. So this is our effort to ensure that the immunologist also play a role in the management of complex allergies and become an important part in allergy management. So what we've designed is a two-part conference. The first part is an online section where you'd have such talks that cover the basic theoretical aspects of allergy so that people understand before coming to a conference the basics of what they are going to practice. And then there'll be a 3 day conclave, which is primarily going to be practical case-based discussions so that you understand the uh, practical day-to-day aspects of allergy. So this is how it is usually going to be. And we've been fortunate to have great faculties like Dr. Sayan teaching us, some of the best people in their field. And it has gone great till now. I hope we have the same great talks and great academic discussions going forward. It is quite unlike any usual conference that you have, more like a certification course or a course that might train you for allergies per se, but that's how it is.
No, sounds like a very good concept. So we'll start in a couple of minutes.
Yeah, I
Great.
think a couple. Yeah, so I think it's just a minute to go. And before we start, I'll just introduce our conference, the chairs for this meeting today also. So we have Dr. Jitendra Jethani. He's a senior pediatric ophthalmologist who practices in Baroda. Uh, and we have Dr. Hardik Rathod. He's a rheumatologist who practices in Ahmedabad. And both of them will steer the meeting uh, today. So I think I'll pass the baton over to Dr. Jitendra to introduce Dr. Sayan and carry the meeting forward.
Thank you so much, Dr. Kunal. And in fact, it's an honor to introduce Dr. Sayan, who is really a doyen in not only ophthalmology, but his deep interest is there in ocular surface disorders. And we in ophthalmology, he's a go-to person for all of us who have, patients or complicated, complex cases. We all referred him to him, and he has been a mentor for people who are into cornea and ocular surface disorders. Truly, it's an honor, and I would introduce Dr. Sayan Basu. He is a professor, the Balasubramaniam Chair of Eye Research. and he serves as the director of both the Professor Brandholden Eye Research Center and Center for Ocular Regeneration. He is also an adjunct associate professor of ophthalmology at University of Rochester, New York. We all know him that he's a clinician, scientist, and a key opinion leader in corneal and ocular surface disorders and allergic disorders of eye. And he has indeed significantly contributed to advancements in regenerative medicine and transitional research. He has, he has really, his high commitment is towards mentoring his fellows, faculties, and PhD students. Uh, his publications, almost 260 peer-reviewed articles in international scientific journals, and he serves on editorial boards of several prestigious publications. So that tells the volume of work he has been doing in cornea and allergic disorders. So he is a member by thesis of Cornea Society, which is a huge recognition and has received achievement awards from American Academy of Ophthalmology. So with this, I will move on to Dr. Sayan Basu for his presentation, today's presentation on allergic disorders. Thank you, sir, for joining us.
Thank you, Dr. Jethani, for the kind introduction, and thank you, Kunal, for the invitation and making me a part of this meeting and this session. So I'll just share my slides first and then get started. I would request everyone to engage and ask questions, and feel free to stop me if you want in between to clarify anything. I have kept the overall sequence and flow in a way that we can understand this enigma of a disease in a way that we can apply that knowledge in helping our patients. So something which is practical, rooted, and also very relatable. So this is an allergic eye disease simplified in the sense that I basically try to distill the understanding that I have of this disease. A lot of the published literature on this, a lot of the research that has been done, that our group has also done on this condition, and what is our current understanding of what it is. I think that there are a lot of terminologies and there are a lot of concepts that sometimes get intermingled, and we tend to use terms very loosely, and which adds to the confusion. So the entire main objective of my talk essentially is to demystify this condition, and also to reduce the confusion and the controversies that exist regarding its treatment. Okay, so we are basically talking about allergic conjunctivitis. I'm sure all of you know, the anatomy of the eye. So the ocular surface is where this inflammation takes place in the conjunctival tissue. The conjunctival tissue is very richly supplied by blood vessels and also with lymphoid tissue. So it is a very ideal target for any kind of inflammation and immunological reaction. And therefore, the allergy that we see in patients in the skin and in other mucous membranes also happens in the conjunctiva as well. So allergic conjunctivitis is nothing but eye allergy, and this causes inflammation of the ocular surface of the conjunctiva, which is a large part of the ocular surface is just conjunctiva. So if you are looking at somebody's eyes, from the eyelids, starting from the back surface of the eyelids to the entire surface of the eye, except for the surface of the cornea, everything is conjunctiva. It has different parts. That which is lining the back surface of the eyelid is called the tarsal or palpebral conjunctiva. The folds in between the lid and the eyeball is called the fornicial, and on the surface of the eye is called the bulbar conjunctiva. So when there is inflammation of the conjunctiva, patients have red eyes, and this is exactly what allergic conjunctivitis looks like. It is associated with itchiness of the eyes. This is very, very, classic. And you really cannot diagnose somebody with ocular allergy if they don't have itching. And because they have itching, and because a lot of the patients who are suffering from eye allergy are children, this results in a lot of eye rubbing, which can become habitual in these patients, particularly in children. like I said, mostly affects children, and within children also it mostly affects boys. And this I think is true for most kinds of allergy, and it has some hormonal basis. Allergic conjunctivitis will usually rarely affect adults, although it's not that it can't, but it's very rare. Childhood allergy is much more common, just like any other allergy. But I guess, unlike other forms of allergy, unless somebody moves to a new place and have not been exposed to something that they find themselves allergic to, usually allergic conjunctivitis in adults extremely rare. There are a few subtypes that occur in adults, and we'll discuss them. Okay, so this is the basic understanding of allergic conjunctivitis. Now, how do we diagnose this? So, can you diagnose, do you need an ophthalmologist to diagnose allergic conjunctivitis, or can anyone diagnose a patient with allergic conjunctivitis? It's a very interesting question. So, you would highly suspect eye allergy in a child who has bilateral red, watery, itchy eyes. Okay. So, a child with both eyes are red, they are itchy, there's discharge, there's watering, very likely that it has allergy. However, you can have this condition, you can have the same presentation in patients with infectious conjunctivitis also. So, if somebody with bilateral red eyes, itchy eyes, watery eyes may not necessarily be allergy, it could also be viral conjunctivitis or bacterial conjunctivitis. So, the most important clinical differentiator or clincher that will help you diagnose in a child who has bilateral red itchy eyes that child has allergy is the presence of conjunctival papillary reaction. Okay, so to see whether the conjunctiva has a papillary reaction or not, you would need a slit lamp, and that is where the role of an ophthalmologist comes in. So I guess the answer to the question is that you can, in most cases, suspect very accurately that somebody, a child with bilateral red, itchy eyes, watery eyes, has allergic conjunctivitis. But just to make sure that you're not confusing it with viral conjunctivitis, where the treatment is different, or with bacterial conjunctivitis, which is much rare, but it can still happen. You need to look for conjunctival papillae. And for conjunctival papillae, you probably need to ask your ophthalmology colleague to take a look, because it would require a slit lamp. So what is conjunctival papillary reaction? So what you see on your left, this is an extreme form of papillary reaction, but typically these papillae are present in the upper tarsus, the inside of the lid. And it indicates, it's very pathognomonic of an allergic response or an allergic condition. The reason that you see papillae on the tarsal conjunctiva is essentially because the tarsal conjunctiva is very closely adherent with the tarsus, and there are these septae which are holding the conjunctiva tightly to the tarsus. And when the conjunctiva becomes grossly inflamed, then the areas in between these septae, they become like these blocks which get elevated, and like cobblestone, and then this looks like this is basically what is called papillae. So because of this specific anatomical predisposition, you see papillary reaction only in the upper tarsus. It's very, very unusual to see papillary reaction in the lower tarsus. Okay. The other differentiator which helps you to distinguish between allergic conjunctivitis and infectious conjunctivitis is a follicular reaction. Now, these two terms are often confused. The papillary reaction is in the upper eyelid, upper tarsus. You invert the upper eyelid and you look for the tarsal reaction, the papillary reaction. Whereas a follicular reaction is usually seen in the lower fornix. So you retract the lower lid to look for this. These are small whitish globules that you see in the lower fornix, and these are nothing but basically inflamed lymphoid tissue. So when you have infection, you have this, these are like the lymph nodes of the conjunctiva. These lymphoid tissue, they get inflamed and or hyperactive or active, and they look like these round whitish globules in the. So this is not in the tarsus, it's in the fornix. So if you are going to diagnose allergic conjunctivitis, you need to elicit a papillary reaction in the upper tarsus, and you need to rule out a follicular reaction. If you see a follicular reaction, then you're thinking of infectious conjunctivitis. Now, the conjunctival papillae also come in various shapes and sizes. What I showed you in the previous slide was a large or giant papillae, but you can also have much more subtle papillary reaction, as you can see in the photograph on the left. So the papillary reaction can also be mild or micropapillae. And you can have a spectrum which is in between. The presence of bilateral conjunctival papillae is very, very pathognomonic of ocular allergy. Whereas if you have only papillae in one eye, although that is an allergic response, it is not allergic eye disease which is causing this. It is typically a hypersensitivity response to a presence of a foreign body. So even with the papillary reaction, the papillary reaction alone is not indicative of allergy. If it is unilateral, then you need to rule out a foreign body somewhere in the eye, which can cause this. Somebody wearing a contact lens for a long time can also, for example, have a papillary reaction. But it's usually unilateral. If they use in both eyes, it can be bilateral. So how do you diagnose allergic eye disease? To summarize, you have a child typically with red itchy eyes. When you suspect it, you need to differentiate it from infection by ruling out follicles and by ruling in papillae, and make sure that the papillae are in both eyes. So once you have diagnosed somebody with allergic conjunctivitis and shown that there is papillary reaction in the palpebral conch, then you need to categorize or type it. What kind of allergic conjunctivitis is this? Now, this is important because depending on the type of conjunctivitis, your treatment will differ. So this can either be, there are basically four classical types: seasonal allergic conjunctivitis, perennial allergic conjunctivitis, vernal keratoconjunctivitis, and atopic keratoconjunctivitis. Now, these words are also kind of, they have specific connotations, and that is why I'm trying to explain this in a simple way. Seasonal allergic conjunctivitis and perennial allergic conjunctivitis are basically a very, very conserved IgE responses like regular allergy. And seasonal is you have these exacerbation of flare-ups that happen during a specific season. Whereas in perennial allergic conjunctivitis, it is basically the same as seasonal allergic conjunctivitis. So PSC is very similar to SSC, except that the child can have allergy at any time. It does not have a specific seasonal predilection. So it is probably in reaction to an allergen which is there at home or at school or somewhere that the child is frequently exposed to, and it has nothing to do with the season. But the underlying mechanism of seasonal allergic conjunctivitis and perennial allergic conjunctivitis is the same. It's totally IgE mediated. Whereas vernal keratoconjunctivitis and atopic keratoconjunctivitis have a dual pathway which involves both, humoral and cell-mediated immunity, and therefore it can have tissue changes which can lead to other complications. So in vernal keratoconjunctivitis, these complications are mostly in the cornea. In atopic keratoconjunctivitis, it can be in the cornea and in the eyelid. Now, atopic keratoconjunctivitis has a specific connotation. Atopic keratoconjunctivitis does not mean conjunctivitis with atopy. Atopic keratoconjunctivitis is a specific term because it has a specific phenotype that is used for a disease like VKC, which is present along with atopic dermatitis and typically periocular dermatitis. So these patients, because of their eye rubbing, they also develop contact dermatitis around the eye, and this contact dermatitis leads to skin changes, especially around the lower eyelid, sometimes which can lead to lower eyelid cicatricial changes, and that is basically the pathognomonic feature of AKC. AKC essentially, for all practical purposes, is VKC with atopic dermatitis or contact dermatitis. If you have VKC without contact dermatitis, then we just call it VKC. This differentiation is important. The other important thing about AKC is extremely rare. We don't see it in India much, and it is typically in young adults and in elderly that we see AKC, middle-aged or elderly. Whereas SSC, PSC, and VKC are almost exclusively present in children. VKC can also occur in adults, but it's extremely rare. Whereas AKC is mostly a disease of adulthood onwards. Now, therefore, the first, if we go step by step, we understand what is allergic eye disease. We have learned how to differentiate it from other conditions which may have red, itchy, watery eyes like infectious conjunctivitis. We have established papillae, and so we know this is allergy. Now we are trying to differentiate between SSC, PSC, VKC, and AKC. Like I said, AKC is adults, so you leave to one side. It's also very rare. You hardly ever see it. Whereas children with allergy is more common. And therefore, in children with allergy, you're essentially trying to differentiate whether this is SSC, PSC, or VKC. Now, how do you make this differentiation? Now, these definitions in literature are not very clear. And therefore, these are easily confused. A lot of people call all childhood allergy VKC, which leads to sometimes excessive treatment. Sometimes this differentiation is not made. Everything is lumped together as allergic conjunctivitis, which also does not help with its treatment. So I think this differentiation is very important because it fundamentally determines or directs how you treat children with allergy. So if you have a child with red, itchy eyes who has a conjunctival papillary reaction, you know now that you're dealing with a child with allergic conjunctivitis. It's important now to find out whether this is seasonal, perennial, or vernal keratoconjunctivitis. So how do you know that this is SSC or PSC? It is basically a diagnosis of exclusion. So if the child does not have VKC, then the child must have SSC or PSC. So depending on whether it happens only during a specific season or it can happen anytime during the year, that's how we label SSC or PSC. So how do we then diagnose VKC? VKC is a very specific form of childhood eye allergy where the child must have at least one of the four. Okay, and usually a combination, at least two of these. So either large macropapillae, like we showed earlier, so not just papillae or not just a micropapillary reaction, but large papillae. Second is, along with that large papillae, typically you will see ropey discharge. So ropey discharge is this very thick discharge which gets trapped between the papillae in the little bit of space that is there between the papillae. It gets stuck over there, and the children will often evert their eyelids themselves and pull down. And it's extremely discomforting, and they have to do that first thing in the morning to be able to open their eyes. So this very thick ropey discharge which gets trapped within the papillae is also it's very specific for VKC. The other is limbal inflammation, or what is called Horner-Tranter's dots, or a specific type of muddy bulbar conjunctival pigmentation. So if you see a child who you have diagnosed with allergy has any one of these, Horner-Tranter dots, macropapillae, ropey discharge, or bulbar conjunctival pigmentation, then this child has VKC. Then it is not SSC or PSC. Why is this differentiation important? And what are these signs that I'm talking about? So we already talked about macropapillae. If you have this ropey discharge which is trapped in between the macropapillae, or you have these Horner-Tranter dots or limbal inflammation. So limbal inflammation means the area between the conjunctiva and the cornea, which is the limbus that is inflamed, like you see in the bottom two photographs. There's thickening, whitening, and you see these white dots. And these white dots are called Horner-Tranter dots. You can have limbal thickening without the dots also. And typically these patients will also, if there is limbal form of VKC, they will have muddy bulbar conjunctival pigmentation. So typically in those children who otherwise are ethnically pigmented, then they will also have this pigment dispersion, brown pigment going into the conjunctiva. That is also very specific for VKC. So you label somebody as VKC if they have one or more of these four features. Otherwise, it's SSC or PSC. So how does this help in our treatment? If it is a patient child with SSC or PSC, then these are very well managed by mast cell stabilizers or antihistamines. Nothing else is required. So steroids are also overkill in these patients because this allergy is not so severe. You can just give them olopatadine eye drops, and you can ask them to keep the parents to keep the olopatadine eye drops in the door of the fridge or use it chilled. So the chilled eye drops themselves will act as vasoconstrictor and help in the allergy. And just a short course of a couple of weeks is enough. So typically a child who first time presents with allergy, this has never happened before. There's no macropapillae, no Horner-Tranter dots, no bulbar pigmentation, no ropey discharge, just give them olopatadine eye drops. That's it. And it may happen again, it may not happen again. Most children develop tolerance, never happens. If they have any of these signs and you have diagnosed as VKC, the reason that they have these changes, large papillae, muddy conjunctiva, ropey discharge, limbal inflammation, Horner tundra, is because of three things: severity, chronicity, and recurrence. So, because the amount of inflammation in VKC is more, therefore the manifestations are more severe. So, in these cases, olopatadine is not enough. So, all patients who you diagnose as VKC will require a very short tapering course of topical steroids or steroid eye drops. And typically, we recommend using loteprednol 0.5% eye drops. You can give them a 3-to-1 course of 3 weeks or a 4-3-2-1 course of 1 month, depending on the inflammation. And typically, that will act very well. In patients who have very severe inflammation, sometimes you even need to give something stronger like prednisolone or flomethanol or betamethasone, but usually loteprednol does the job. Now, if these children with VKC also have year-long inflammation, which means that they have these acute flare-ups, but otherwise during the course of the year also they can have, and it's unpredictable when they have it. If you're going to give them prophylaxis, then again, for VKC, giving prophylaxis with a mast cell stabilizer or an antihistamine is not enough, because it is not simply IgE mediated. And therefore, you need to give them something which is more targeted towards the pathogenesis, pathophysiology of the disease, which is we usually give them topical calcineurin inhibitors. So either topical cyclosporin or topical tacrolimus. In children, typically tacrolimus is better because it comes as an ointment. It can be given once at night. It has a longer contact time. In young adults, they don't like ointment, so you can give cyclosporin eye drops. So this slide is very important because what it tells you is that it's important to differentiate SSC, PSC from VKC, which most people don't pay a lot of attention to. And therefore, there's a lot of overprescription of steroids in children who don't need steroids. And there's an underprescription of steroids in children who actually need steroids. SSC, PSC, no indication for steroids, no indication for cyclosporin, simply olopatadine because it's dual acting, works very well. Or you can also give sodium chromoglycate or kerotiphen, etc., which are single acting agents. VKC, short course of topical steroids, typically loteprednol, and year-long prophylaxis with cyclosporin and tacrolimus. Now, you can have VKC associated with contact dermatitis, and then this is what we call AKC. So you have this presentation where you have severe dermatitis, especially periocular dermatitis. And this is basically just a more severe form of VKC. Typically, it does not affect children, but can, usually young adults and middle-aged or elderly. The chances of corneal complications in AKC are much more common, and the treatment is slightly different. The reason it is slightly different is, again, it's one step above VKC. There's more inflammation, more tissues are involved. Other than the ocular surface, the skin is also involved, and they have a predilection or a tendency to develop more corneal complications. So the morbidity in terms of corneal complications and severe blinding corneal complications is more in AKC. Thankfully, it is very rare, and we hardly see it in India. How is it different, the treatment of AKC from VKC? In addition to what we do for VKC, which I said, topical steroids whenever there's inflammation, prophylaxis with cyclosporin and tacrolimus, you would also need to give these patients with AKC oral antihistaminics, probably. You need to refer them to an allergist to do testing to see, because they are having more severe and multi-system involvement. So there could be something at home or something at work that they're allergic to, which they can avoid. Most commonly, these are like ticks or other things which can be taken care of, mites and other things that can be taken care of. And in these patients also, we have a lower threshold for systemic cyclosporin or tacrolimus in patients with OKC. Sometimes they need to be given systemic steroids. Okay, so this is like the basic context of what I wanted to talk about in managing allergy. And in the last 10 minutes or so, I will take you through when we have done all of these, or if these steps have not been followed properly, which is very common. then you end up with more severe cases which need a slightly different approach. So I'll give you a few examples and then we'll discuss. So for example, this 14-year-old boy who had symptoms since the past 8 or 9 years, the parents are tired of putting eye drops. They want a permanent cure, very severe papillary reactions. This is a child with VKC with severe inflammation in the eye. Or this child who's 9-year-old, symptoms since 3 or 4 years. Again, parents tired of putting drops. Now there's this white opacity which they are seeing in the eye. So you can see the Horner Trantador. So this is also VKC. This is a 15-year-old boy with AKC. So has allergic rhinitis, dermatitis, alopecia, asthma. There's a separate set of medications for each ailment. Has severe papillary reaction. Also has corneal changes. And a 7-year-old boy, excoriation of the eyelid skin. Again, AKC, visited 13 ophthalmologists already, and now is starting to lose vision. And you can see how bad the ocular surface looks in this photograph. Okay, so VKC, like I said before, is a little different from SSC and PSC, because not only do we have the IG mediated pathway, but you also have the TH2 mediated cellular pathway, which ultimately is because of is responsible for the chronicity and the tissue changes that happen in VKC. VKC is in terms of eye allergy, the most common type. It is also the type of allergy which causes the most amount of morbidity. So therefore, we need to discuss it a little bit more detail. Thankfully, this is also self-limiting, starts in early childhood, dies away by adolescence, but it can last several years, unlike SSC and PSC. And therefore, like I said, it should be diagnosed correctly. Topical steroids should be given, and we should prevent these children from getting into the vicious cycle of inflammation. But sometimes children do get into the vicious cycle of inflammation, and then they start to develop other complications. Fortunately, this is very, very rare. In our study, in which we looked at thousands of cases of allergy, I think almost 45,000 patients with eye allergy, or 25,000 patients with eye allergy, we found that this kind of chronicity and chronic changes was seen in only about 1%. So 99% of VKC will be short-lived, and we will be able to control them with short courses of topical steroids. But in about 1%, it gets out of hand. And these patients typically develop either complications of frequent use of steroids, which is like steroid-induced glaucoma or cataract, or they will develop corneal complications like keratoconus, limbal stem cell deficiency, scarring, amblyopia, and so on and so forth. So this is where oral steroids, oral calcineurin inhibitors like cyclosporine tacrolimus, or biologics like omalizumab are indicated in this 1% of cases of VKC which get out of hand. These are called refractory cases or recalcitrant VKC. Okay, so whereas like I said before, the reason that in VKC we like to give cyclosporine either topically or in severe cases systemically is because it is very specific for this cellular pathway, which is responsible for the chronicity and the tissue changes that we see in VKC. So we did this study looking at what is the effect or benefit of using cyclosporine. Now, currently, we use tacrolimus more frequently. But historically, when cyclosporine was cheaper and more easily available, we used to use cyclosporine. So in this study, we looked at a large cohort of cases who were having this kind of recalcitrant VKC and gave them cyclosporine. What we found is that before and after cyclosporine, the main difference was in the amount of steroids that these children needed. So if you look at the summary of the outcomes before oral cyclosporine initiation, these patients had 42 episodes over a period of 403 person months, whereas after initiating cyclosporine, they had only 10 episodes over a period of 250 person months. So that's about a 1/4 reduction, or at least a half reduction if you compensate for the follow-up. So the odds of developing an acute episode was 2.6 times higher for these children or these patients without oral cyclosporin. When they use oral cyclosporin, there was a 2.6 times lower risk of developing an acute episode. The other important benefit of using oral cyclosporin was that these patients continued to have disease remission even after cyclosporin was discontinued. And this was usually given for between 6 to 18 months. And also that they did not have any progression of pre-existing sequelae in these cases during the treatment with cyclosporin or after cyclosporin was stopped. Oral tacrolimus also has the same kind of benefit. So I'll just show you some of the impressive outcomes. I showed you this photograph before of a child with a giant papillae. This is the same case after oral cyclosporin use, where you can see that the macropapillae have been converted into micropapillae. The tarsal inflammation is almost gone. This is the left eye of the same patient where I showed the ropey discharge, and you can see that this is also gone. This is a child with limbitis. After cyclosporin use, you can see that the limbal inflammation is completely gone. You can see the residual pigment that is there on the bulbar conch, but otherwise it's just scarring. There is no inflammation in the eye. The eye is quiet. This teenager with atopic dermatitis and severe allergy, even his dermatitis got better, and the shield ulcer was scraped, and it resolved, and he recovered vision, and his tarsal inflammation was almost completely gone. This young boy with limbitis and ocular surface breakdown, again, complete recovery with oral cyclosporin. This is another case which was referred to me for a stem cell transplant, but we started him on cyclosporin and he got better, and he subsequently never required that transplant. This patient, happens to be from Gujarat, actually from Ahmedabad. And this is another interesting case, which, we were actually planning to do a stem cell transplant. Even I was convinced that this was beyond salvage. But because we were planning a stem cell, and usually because this is bilateral, when we do stem cell transplantation surgery, we have to take the stem cells, the limbal stem cells from a donor. So we need to start them on oral cyclosporin or tacrolimus anyways. So that is what we had done in this case. And when the patient actually came for the transplant about a month later, you can see that the inflammation is already resolved. So in this case, we didn't actually have to do surgery, although we intended to do surgery, and we started tacrolimus not for the disease per se, but for preparing the child for surgery. But you can see how well that has controlled the inflammation, and the child recovered. The allergy was gone, the itching was gone, and the vision had also recovered. This is the other eye of the same patient. You can see how severe the inflammation was, with Horner-Tranter's dots and the conjunctivalization of the cornea. You can hardly see the cornea or anything inside the eye. And this is the same eye post treatment with oral cyclosporin. So just to come to the last few slides, and then I hope that we can take some questions. 95%, fortunately, of all allergy, and if you include SSC and PSC, then it's true for that also, will resolve only with topical therapy. In SSC, PSC, olopatadine; in VKC, pulse steroid. So maybe once a year, twice a year, give them a couple of weeks of topical loteprednol. That's enough. Systemic therapy is only indicated in this 1% of all VKC, where either it is happening so frequently or it is so severe that you have to use topical steroids so often that the risks outweigh the benefits. It is effective in controlling the acute exacerbations, oral cyclosporin. It also reduces the need for corticosteroids. So if you have a patient with VKC who is on frequent corticosteroids, as recalcitrant to topical steroids, or is developing complications to steroids, then you definitely need to consider it. It works very well. Omalizumab also works very well. It is just that it is more expensive and not that widely available or affordable. Cyclosporin, you can think of it as poor man's omalizumab. In those cases where we progress, like I said before, to limbal stem cell deficiency and end-stage ocular surface disease, we can then give them oral cyclosporin or tacrolimus and then do stem cell transplantation from a donor, and then those cases can also recover very well. So this is a patient post a stem cell transplantation on oral immunosuppression, maintaining good vision. And like I said, in this case I showed before that where we planned stem cell transplantation, but with oral cyclosporin, it was avoided because the cyclosporin worked. So even in cases where systemic, where you have complications like limbal stem cell deficiency, You can control that with stem cell transplants. You can reverse that, but in many cases, you can just control it. And even if you're doing stem cell transplant in one eye, the immunosuppression helps with the other. So I talked towards the end of my talk today about the role of oral cyclosporine. So one of the things that you may wonder is, why is this not popular? First of all, you have to understand, like I prefaced when I was saying that we are only talking about these 1% of recalcitrant cases of VKC where it's indicated. So first of all, it's not so common to have children who are not responding to topical steroids or requiring it so often, etc. But even among those patients, first of all, is that oral medications, ophthalmologists are not so familiar or comfortable with prescribing oral medications. And so it is not commonly used. Um, Although ophthalmologists will very commonly use topical cyclosporine, they are not very comfortable in using systemic cyclosporine. Often ophthalmologists, will refer these patients to you for systemic immunosuppression. However, rheumatologists, may not be so comfortable or may not have as much experience with cyclosporine as, let's say, transplant surgeons who are more comfortable with it. So, this is something that there needs to be a little bit of communication between these different specialists who are using these different medications. So the ophthalmologist has no experience with oral cyclosporine. The rheumatologists who have more experience with like drugs like mycophenolate or azathioprine or biologics may not have as much experience with cyclosporine because they're not using it as much. And so they are not able to, and rheumatologists, unlike ophthalmologists, are more responsible, I think, in prescribing systemic medication. So they're very by the book. So if there's no evidence for it, they'll not use it. And therefore, that is also comes in. Now we have a lot of evidence, but it's in ophthalmology literature. It's not in rheumatology literature. There's also typically a lot of reluctance amongst ophthalmologists to use oral immunosuppression in children and adolescents because inexperience and they don't know what will happen. Actually, it's giving cyclosporine or tacrolimus is a little bit safer in children and adolescents than it is in older patients because the risk of the cardiovascular problems is not there. So this is what I tell to my ophthalmology colleagues, that think of oral cyclosporine, and in the doses that we give, they're not very high doses, 2 to 5 milligram per kg body weight per day. And it's not for a very long duration. It's about between 6 to 18 months, depending on the severity. To think of it as, topical cyclosporine given orally, that you give the patient oral cyclosporine, controls the oral allergy, and the cyclosporine also comes out in the eye as a preservative-free drop through the lacrimal secretion. And you can, this is what I say to allergists and to immunologists, that you can think of oral cyclosporine tacrolimus as, in chronic ocular allergy, as poor man's omalizumab. So if the patient can't afford omalizumab but is not controlling other medications, you can definitely consider it. We have very good experience with it. So I'll finish with this, that if you're managing patients with ocular allergy, first is to diagnose ocular allergy correctly, particularly in children, differentiating from other conditions that cause conjunctivitis. Identify the subtype. Basically, subtype means rule out VKC or rule in VKC. If you have seen the four cardinal signs, one of the four cardinal signs of VKC, then treat it as VKC, which is topical steroids, and long-term maintenance with topical cyclosporine or tacrolimus, depending on the age. If it is not VKC, then treat it as SSC or PSC, which is overbearing. So don't overprescribe steroids in patients with seasonal or perennial. Don't underprescribe steroids in patients with VKC. The problem that I see a lot of times is patients unnecessarily on steroids when they don't have vernal keratoconjunctivitis, and a lot of vernal keratoconjunctivitis patients are odoparatine, which is not really effective in VKC, and that's why they keep having recurrences and other problems happen. And then if you have chronic VKC, then you use systemic therapy. The other thing that needs to be kept in mind is that anybody with allergy which is not being controlled with this algorithm or this stepladder approach, you need to consider sending that patient over to an allergist. They can do, look for if they have any specific, if they are hyper-specific allergens, and then if that avoidance is possible or any kind of remedy is possible, or even sublingual immunotherapy in some patients where all of this has failed helps. And lastly, after SSC, PAC, VKC, AKC, which is in adults with allergic dermatitis. The treatment is like severe chronic VKC, but in those cases, you also need to work with the dermatologist, and they might give some oral medications for the skin, which will help with the eye allergy as well. Okay, so I will stop here. Thank you so much for having me, and it was absolutely wonderful to share what I have learned about allergy with you. I'm very happy to take any questions that you may have. Thank you so much.
Thank you so much, sir. It was an excellent session, excellent. And I think that's the reason we have a lot of questions in the question box. I think Jitendra sir and Hardik can roll over them quickly so that.
Excellent presentation. As usual, you have been bang on target, excellent literature search, and you have yourself done so much phenomenal work on all this. So we have a list of huge list of questions. We will just quickly. I know you will have really great answers. I'm just quickly going through them. Dr. Namrata Agarwal wants to ask how frequently we get raised IgE levels in VKC. And I just want to add a second part to it, whether you can differentiate on the basis of IgE levels between VKC and perennial allergic conjunctivitis.
I don't in eye allergy. I don't think there is any role of doing IgE. I think even in patients where the allergists or immunologists consider giving biologics, also they don't really. I don't think they do IgE levels, or maybe there might be an indication for doing that. But in terms of just managing the eye allergy as an ophthalmologist or as a rheumatologist, you will not really depend on IgE levels much. They don't really tell you much.
So you don't really have to differentiate whether it is IgE mediated or non-IgE mediated, not from the ophthalmological point of view, but from the allergy specialist point of view.
So Ig involvement is there in all types of allergy. It's just that in VKC, AKC, you have other additional pathways in addition to Ig, and the Ig levels are not very specific. So I don't think they're very helpful. That's the thing.
Dr. Meena wants to ask what do cystic changes at limbus in patients of chronic VKC signify?
Again, it just signifies chronicity. So you can have this limbal cyst. I showed one photograph also where not only your limbal cyst, your cyst in the center part of the epithelium also. So these are basically just signs of chronicity and severity of inflammation. You can have these cystic epithelial changes.
Dr. Akansha Sinha asks whether if you recommend prophylaxis for perennial allergic conjunctivitis.
Yes, a perennial means child will have throughout the year. It's not seasonal. You don't know when it will happen. So give them olopatadine to use throughout the year. Nowadays, we also get preservative-free olopatadine, which is very good. We did not have that before. And my only recommendation there is that ask the parents to keep the olopatadine eye drops. You can give Chromalfort also, but since olopatadine now is available preservative-free, I recommend it. Ask them to keep it in the door of the fridge. So it's BD dose. They can put one drop before going to school, and they can put one drop after coming back, and that usually works very well.
And do you use the newer one, the higher concentration, 0.07% or something like that, Olopet Max or something? Does
I
it have
think
any additional benefit?
I don't think that it has any additional benefit. I don't think there's a lot of literature on it also, so it's difficult to recommend. That's all.
Dr. Kapil wants to ask any role of oral medications like Montelukast or E-Blast or Cetirizine, etc. in older kids?
Not in only eye allergy. If they have also, dermatitis, etc., or asthma or bronchitis, maybe.
Dr. Anamika has a question. Skin ointment tacrolimus concentration 1%. I think we have 0.3, 0.03 and 0.3.
Skin ointment can be considered if they have atopic dermatitis around the eye, then use the skin ointment. Otherwise, the 0.3 that we have for the eye is pretty good.
We have a question from Dr. Sumaya's iPhone, sir. Year-long cyclosporin or tacrolimus. So basically, they want to ask how long should be the dose of cyclosporin or tacrolimus in children with VKC.
So topical cyclosporin or tacrolimus, if you are using, it's very safe. You can use it long term. Oral, like I said, in these very severe cases, we give, and usually it's between 6 months to 18 months, depending on the severity.
6 months to 18
Topical cyclosporine to tacrolimus, there is no contraindication or there is no minimum maximum. It's very safe.
Okay. Oral comparison, Dr. Reddy wants to ask if between a choice between oral cyclosporin or oral tacrolimus, which one is safer and better? I mean, efficacy wise and safer in terms of side effects.
Topically, there is no difference. Systemically, tacrolimus is preferred over cyclosporin. Tacrolimus is preferred over cyclosporin. The dose is 100. So if you're going to give somebody 50 milligram BD cyclosporin, you would give 0.5 milligram BD for tacrolimus. Nowadays, a lot of generics are available. Of course, you need to choose the generic based on some track record, not just use anything. But what I'm trying to say is it's not now expensive anymore to use tacrolimus. And in fact, it is maybe some medications are cheaper than cyclosporin. So nowadays I use tacrolimus and usually around that dose, 0.5 milligram BD or 1 milligram.
So Dr. Amata has a question: if the child develops shield ulcer grade 2, 3 and needs amniotic membrane grafting, in the post-op course, shall we start oral cyclosporin?
So,
and how long?
Oral cyclosporin, you have to understand, is more like getting somebody who has chronic inflammation out of that vicious cycle of inflammation. If somebody has acute inflammation like a shield ulcer, then you have to give them topical steroids 100%. But if you're giving starting oral cyclosporin, it is not for treating the inflammation now. It is for getting them out from the vicious cycle of inflammation. It's like more like a remission therapy or getting people out of that chronic cycle of inflammation. If I have inflammation now, if you give me oral or topical cyclosporin, it's not that effective. It's not that potent.
Dr. Shama Saudagar has a question. After limbal stem cell transplant, what immunosuppression do you use and for how long?
So either tacrolimus or cyclosporin. Now we prefer using tacrolimus. And usually between 18 months.
If you're doing...
sorry.
Yeah. This is Dr. Sharma, sir. Actually, after listening to your lecture, yesterday only I got a patient, a 4-year-old child referred from ophthalmologist actually, after a allogenic limbal transplant. So post chemical burns, he has actually referred to me for starting immunosuppression. So I just wanted to know how to go about it, because the ophthalmologist has actually not written any plan like what immunosuppression to choose or what doses to give. So after listening to your lecture, it really made me sense like to ask whether how to go about it.
So you will usually start with oral steroids and oral tacrolimus, and then taper off the oral steroids in about 6 to 8 weeks, and keep the patient long term on oral tacrolimus. So depending on the age and the weight, you can choose a dose. Usually the dose is, like I said, for cyclosporin is between 2 to 5 milligram per kg body weight, and tacrolimus is 100 of that.
Okay, sir. How about if there is any kidney problem? Is it okay to go with mycophenolate in addition to steroid?
Mycophenolate is also very good, because tacrolimus is usually preferred for, solid organ transplants or for any kind of allogenic transplants. Mycophenolate, azathioprine, all of these medications are more useful, like, as rheumatologists, you'll use in these kind of autoimmune diseases. But in transplant, high-risk grafts, we prefer using calcineurin inhibitors.
Sure, sir. Thank you very much.
But you can use mycophenolate also.
Okay, sir. Thank you. Thank you so much.
There's a question by Dr. Akshay on what dose of steroid do you prefer to initiate the patient with, and can you outline a tapering schedule for severe VKC?
So typically, I will prefer using loteprednol. I will almost never use prednisolone because of the side effect profile and overkill in ocular surface disease, unless I've done intraocular procedures or patient has intraocular inflammation. So loteprednol, you can start 4 times, and then based on the chronicity and the level of inflammation, either do a 3-to-1 over 2 weeks each, or do a 4-3-1 over 2 weeks each, or a 3-to-1 or a 4-3-1 over 1 week each. So depending on what is your baseline where you're starting.
And in addition to that, if oral steroids also have a role in VKC, like when would you like to start the oral steroids?
Oral steroids are also very effective. The only problem with oral steroids is that you can't give it for very long.
Yeah.
Because the systemic side effect profile is so much. So, as the best dermatologist will agree with me, the best immunosuppression in terms of potency remains steroids, but you can't give them for very long. And these are chronic diseases. So, whenever you're giving oral steroids, you must understand that you can't give it for very long. So if the patient you intended to give for very long, then oral steroids is not a very good idea. And these patients will, to get them out of that severe inflammation, it takes many months. So oral steroids are effective, but it's not sustainable.
And,
Sometimes if inflammation is a lot, we'll start with oral steroids and cyclosporine or tacrolimus, and then taper
gradually
off.
take out the steroids. Yes. So, in infants or children less than 2 years, what antihistaminics do you prefer? This is a question by Dr. Parvi.
You can give oloparadine. I mean, it doesn't really have any problems.
There are two questions on SLET. Dr. Rashmika wants to ask for how long you consider on oral immunosuppression before deciding not to go for SLET, and what are the criteria for doing SLET in LS limbal stem cell, LSCD post allergies? Any minimum requirement of a quiet period before you actually plan to do SLET?
Yeah, I mean, I will usually start them on tacrolimus before, and then do it like, once they have been on tacrolimus for about a month or 6 weeks. And if you see response just with the oral tacrolimus, it will take about 4 to 6 weeks for any significant response. So that is the waiting period before you decide.
Dr. Veena has a question. What is the role of allergen immunotherapy in allergic conjunctivitis? Role of sublingual immunotherapy, role of component resolved diagnostics, just to find out what allergens are and then try to target those particular allergens with the immunotherapy.
Yeah, I mean, if you have a patient or a child in which you have tried everything or has received everything, not responding even to, let's say, if you're giving them tacrolimus or cyclosporin orally, or patient has received omalizumab but has not responded. These are typically the patients you will send to an allergist. Or anybody with chronic recalcitrant allergy, it's good to have that opinion. And if they benefit from sublingual, then the problem with sublingual immunotherapy is that it takes a lot of time and the response is not, I don't think it's as significant, but some patients do benefit. There are some studies there's a recent study that has been published from Narayan Nethralaya which shows that patients benefited, but it's in that subgroup. So you have to find those patients who fit that criteria.
Dr. Anirudh has a question. How long should we wait in a patient on topical immunosuppressants who is not responding to the treatment before you switch over to the oral tacrolimus or cyclosporin? I think same question is by Dr. Uma also. Yeah. Like how long would you like to continue with the topical immunosuppressant before you plan to start them or put them on oral cyclosporin or oral tacrolimus?
Yeah, so just to reiterate, like if you have a child with VKC who has a few episodes a year, then you treat each episode with topical steroids and keep them on long-term topical cyclosporin and or tacrolimus. Okay. Once they start developing, where you decide on oral is when you start seeing tissue changes. So they either are developing because you're having to use topical steroids frequently, they have become steroid responders, or they have developing cataracts or IOP spikes, or that they are developing keratoconus or they're developing LSCD. So that is when you decide, okay, this is now going towards recalcitrant VKC, right? So SSC, PAC, micropapillae, VKC, macropapillae, bulbar pigmentation, Horner tantra, ropey discharge, and chronic VKC is all of this plus keratoconus, steroid-induced glaucoma, cataract, or LSCD. So that subset is where you plan for oral therapy.
I think there's a similar question on whether there's a bridge therapy with oral steroids indicated by starting oral cyclosporin, like when
You can
if
do that. You can do that.
start
As long
steroids
as you understand, the reason I don't say oral steroids is that, because you have to be very responsible with it.
True,
The margin for error in children with oral cyclosporin is probably a little bit bigger, wider than for oral steroids. If everybody starts using oral steroids indiscriminately, it's a big problem. So you have to be, as long as you understand that you're going to give them for a very short period of time as bridge therapy and you have experience with it, it's fine.
As an allergy, it is usually not required. You can do without oral steroids in most cases. So rather not use it.
Yeah, I would not recommend
Yeah.
because problems are more than.
I think it is more like if you don't have anything else and you are very desperate, you may give a short course. That is probably what Dr. Basu is trying to say, that, but not preferably to put them on steroids. I think there's a question whether you do check IgE levels by Dr. Namrata in keratoconus patients.
No. IgE level, there is currently no role of checking IgE levels in the management of ocular allergy.
True.
So it is not indicated for anything. It is not helpful in any.
If alcaftadin is better than olopatadin for SAC and PAC?
There is no such literature. So olopatadin is pretty tried and tested. I'm sure alcaftadin also works very well.
Yeah, more of
there is bepotastin now
available.
Difficult to pronounce names, but any of these is fine.
So there's a question, I think practical question by Dr. Vinati on tacrolimus ointment should be applied over the eyelids or inside the conjunctival sac. Where should we put them?
Yeah, it's a very good question. Two things. One is, what ointment are you using? So if you're using the skin ointment, don't put it inside the eye. If you're using the eye ointment, you can put it inside the eye or you can put it in the eyelids, depending on what you're trying to treat. So if you're trying to treat the periocular dermatitis, either ointment is fine, use it on the skin. If you are using it for the VKC, then of course you would want to put it inside the eye so that there is some contact with the tarsus. Otherwise, just putting it outside will not have contact with the tarsus. Sometimes it is not tolerated very well, but the tolerance develops. So patients will have some irritation, heat, insensitivity, but they will get used to it in a couple of days. If you tell them, then that's fine. The other thing is, never use tacrolimus ointment twice a day. Because tacrolimus ointment is slightly photosensitive. A lot of people develop photosensitivity in the morning. So they'll say, when we get up in the morning, then our eyes become red. If I use this ointment, it's because it's photosensitive. So only use at night and ask them to clean it off if they've used too much in the morning.
There's a question by Dr. Pramod on what is the recurrence rate of VKC post tacrolimus and cyclosporin.
If you can, like I said, if you have a patient who has chronic recalcitrant VKC, where you have tissue changes like keratoconus, like LSCD, or you have steroid-induced complications, and you have started them on oral cyclosporin and tacrolimus, and they are still not controlled, then these are the patients you would send to an immunologist or an allergist to for further evaluation and consider SIT or consider biologics.
Dr. Prashant has asked if there is any penetration advantage of calcineurin inhibitors over mycophenolate in eye, or is it just a matter of evidence?
Calcineurin inhibitors are more specific for the disease pathway, the specific IL-2, TH2 pathway. That's all. Mycophenolate, I'm sure people must have used. I don't have any personal experience, or I don't know of literature where mycophenolate has been used in the management of allergy.
I think there's a question on there was no discussion on supratarsal steroid. If you want to touch upon that point, do you use
supratarsal steroids again are they're very effective. So if you have a patient with a shield ulcer or very bad papillae, and you give triamcinolone double eversion in the supratarsal space just above the superior margin of the tarsus, it very quickly controls the allergy. You have to understand that it's a quick fix. It won't control the allergy at its core. And also you have to be sure that this patient is not a steroid responder, because if you have given supratarsal triamcinolone, you can't remove it. So if the patient's IOP spikes then you'll be in a very difficult position. So I give supratarsal steroids, but only in patients where I have treated the patient before, given them steroids, and I know that this patient is not a steroid responder. So that is something that you have to be careful about.
Dr. Kapil has asked, any tear film test that you do in allergic conjunctivitis?
Any tear film? No, not for clinical management. We do like research, but not for clinical management.
And Dr. Vibha has asked, for chronic cases, how many times or how many cycles we can give steroids? Because these patients are on steroid for many years. So how many times we can repeat the steroids?
So topical steroids, I think if you're giving a child once or twice a year, short courses, it's fine. But if it is more than that and the child is frequently having to use steroids or is self-medicating with steroids, those are the indications of thinking of considering systemic therapy.
Any role of NSAID eye drops?
No role of NSAID.
And if a patient of VKC develops glaucoma, which anti-glaucoma medication is best to alleviate symptoms along with IOP control?
So steroid-induced glaucoma is a very difficult condition to treat. And, you'd refer the patient to your glaucoma colleagues and they nowadays, fortunately, a lot of preservative-free anti-glaucoma medications are available. It's best avoided. If you have a patient with steroid-induced glaucoma, steroid-induced glaucoma is very difficult to treat.
I think that's all. Thank you so much for the patiently, taking up all the questions, and very excellent presentation and very quick answers and a wonderful presentation. Thank you so much.
Thank you so much. Thank you. I had a lovely time. Thank you for the interaction.
Thank you.
Thank you, Kunal.
Thank you, Balaji.
All right. Bye-bye. Good night, everyone.
Good night.
Happy
Good night.
Diwali.
Happy Diwali to everyone.